Syphilis is caused by a gram-negative bacterial infection by a spirochete called Treponema pallidum, which is an obligate parasite and affects only human hosts. The pathology of this disease is complex because there are 4 stages of disease, which progress over a long period of time, sometimes not all of them, and each stage is pathologically distinct. But generally, infection occurs when the pathogen enters the host through mucous membranes or breaks in the skin. T. pallidum is very highly motile, so the spirochete can reach the lymphatic system within hours of initial infection. Most of the damage, which can be pretty quickly systemic and potentially pretty devastating, is actually caused by inflammation and the host's immune response to the pathogen. Primary syphilis is the first stage of the infection. This is when the spirochete invades the endothelial cells and promotes an inflammatory response from the immune system. During this stage, painless canker usually occurs on the mouth, tongue, genitals, or anus, and often these heal kind of quickly and without intervention, which makes them easy to overlook and can make it difficult to catch early on because people don't always know that something is wrong and don't always test. But the bacteria continues to spread even after the canker heals. Secondary syphilis is the most infectious phase of the disease. During this phase, the pathogen disseminates quickly through the bloodstream and affects multiple organs relatively rapidly. The stage is marked by a rash, as you can see in the photos here, on the patient's hands and feet, and lesions also appear on mucous membranes. These lesions are called condyloma lata, and they contain a lot of spirochetes, which is what makes the phase most infectious, is contact with those. Other potential complications include nephrotic syndrome, kidney problems, and potentially, although rarer, syphilitic meningitis, which can occur if the spirochetes invade the brain tissue. The third stage is the latent phase. During latency, the host exhibits no clinical symptoms at all, but spirochetes do still persist in their system, especially in the eyes, the cardiovascular system, and the central nervous system. Transmission is still possible during latency, although it's less common, and it's especially possible during the first year of latency. The phase can last for years, it can last for decades, and in a lot of cases, it actually never progresses past this, either because the patient dies of something else first, or just because it does not progress. Tertiary syphilis is the late stage, the final stage, stage 4. It can take a couple of different forms depending on which organ systems are most affected by the spirochetes. So neurosyphilis involves inflammation of brain tissue and destruction of neurons. This can lead to chronic meningitis, degradation of the dorsal column in the spine, which can cause muscle control issues, so ataxia, and neuropathy. Also, neurosyphilitic patients can experience progressive dementia throughout the later phases of the disease. Cardiovascular syphilis is inflammation of the vessels that supply the aorta of the heart. So this can lead to aortic aneurysm and also valve insufficiency. Gametosyphilis, the final kind, is marked by tissue necrosis. So this happens when guma, so lesions, occur on the liver, skin, and bone, and these lesions are destructive inflammatory cells. So they're soft masses that destroy tissue in various areas of the body. So the image to the lower left here shows gummatous syphilis of the patient's skull and of the patient's skin on their face. There is also a congenital form of syphilis, which occurs when an untreated and infected person becomes pregnant, or sometimes if a pregnant person contracts syphilis. This can be transmitted vertically to the baby, to the fetus. Early stage symptoms and complications involve nasal discharge that contains a lot of spirochetes, so very infectious, rash and lesions, bone malformations, an enlarged liver and spleen, low birth weight, and it can also lead to stillbirths. Later stage, there are complications, defects, such as Hutchinson's teeth, which are shown in the medical illustration to the left. Here, malformations of the jaw. Also, saber shins, seen on the right here, which is a malformation of the tibia that causes bending of the tibia. Also, interstitial keratitis, which is inflammation of the cornea and causes complications with sight and vision and eye issues, as well as deafness. Syphilis can be transmitted through sexual transmission and contacts with lesions. It can also, in the congenital form, be transmitted vertically when a pregnant person is infected and not treated, or when a person who is already pregnant contracts the disease. It usually occurs in vertical transmission only during the primary or secondary stage infection. That's when the spirochete load is the highest. That's in about 70 to 90% of cases. In rare cases, this can also happen during the late latent phase, but only about 10%. The spirochete in vertical transmission is able to cross the placental barrier and then disseminate through the bloodstream of the fetus. In rare cases, syphilis can also be transmitted through blood, and usually that happens with injection drug users who share needles during use. Prevention of syphilis includes regular STI screenings or screenings of people who believe they may have been exposed. Also, prenatal screenings for pregnant individuals who are infected or think they may be infected. Apart from screenings, safe sex practices can prevent syphilis, as well as informing partners promptly if an infection occurs to prevent outbreaks and further spread. Treating syphilis is by penicillin G. This remains the only reliable treatment. It is very effective, and as of now, the pathogen exhibits no signs of penicillin resistance, and there are no resistant strains. Like many sexually transmitted infections, syphilis has been heavily and highly stigmatized throughout history and continues to be. It's associated or has been associated with immorality and promiscuity, and often people who contract the disease are blamed or considered dirty or unsavory. The disease also historically has affected already marginalized and stigmatized communities to a disproportionate degree, mostly due to healthcare access barriers. This includes men who have sex with men, Black and Hispanic communities, people experiencing homelessness, injection drug users, and sex workers. If you look to the right on the slide, the This is an illustration done by a Belgian artist in 1922, warning soldiers coming home from war of what the Belgians at the time called the French pox. You'll see it's a woman surrounded by skulls and bodies in a graveyard. Many European countries had different names for syphilis throughout history, and often they blamed other communities or countries for the spread of the disease. So the Belgians called it the French pox, and the French called it an Italian plague, and the Russians called it a Polish plague. And so there was a lot of blaming other communities rather than working together historically to figure out what is causing the spread and how to stop it. The result of all of this stigma includes reluctance of people to get tested, which makes the disease more difficult to treat and also to control on a population level. It also leads to reluctance to inform sexual partners when people are positive out of worry that they might be shamed or blamed. On a more institutional level, stigma can lead to underfunding in research and in advancements in care, and also lack of education and a reluctance to inform communities, talk about things that have to do with sex, and especially in education of younger people, which is particularly important when talking about STI prevention. The history and ecology and origins of syphilis are somewhat unknown and still debated, but the first recorded case was in Italy in the late 1400s. This led to an outbreak referred to as the Great Pox by the Italians. So this first major outbreak was between 1494 and 1495 during a French siege in Italy. The Italians called it the French disease, and the French called it the Neapolitan disease. So each was blaming the other for its origin. There were three hypotheses for how syphilis came to be on the European continent in the form that we now know it. The first of these hypotheses is the Columbian hypothesis, Columbian referring to Christopher Columbus, and the hypothesis being that in 1492, when Columbus sailed to the New World, syphilis was already endemic there, and in his interactions with the local populations, he and his crew contracted syphilis, brought it back to Europe, and there it spread quickly because since the pathogen was not yet on the European continent, there was very little resistance to it. The pre-Columbian hypothesis suggests that the pathogen and the disease actually existed already on the European continent before Columbus sailed in 1492. And the image to the bottom right shows a skull, and bones like these were found in an abbey in England at a time before Columbus's voyage. And as you can see on the skull, the lesions and marks are marks left on bone by gummatous tertiary syphilis. So that those are areas where the gumma would have started to destroy the bone of the skull itself. The Unitarian hypothesis is the final hypothesis. This one suggests that syphilis in the venereal form that we know it, probably evolved in multiple different places sort of at the same time or at different times, but possibly without relation to each other. There's a possibility that venereal syphilis actually came from other kind of less severe but related infections like Pinta and yaws. These related infections were skin-to-skin contact and relatively minor, but the hypothesis is that when hygiene improved over the course of the 1400s and 1500s, especially in Europe, skin-to-skin contact strains were more likely to die out and go extinct, and natural selection actually favored the much more severe venereal strain, which was less affected by the improved hygiene practices. Later on in American history, from 1932 to 1972, syphilis was the subject of the Tuskegee trials, which were a huge turning point in medical ethics and human study ethics. These trials were done in Macon County, Alabama. They enrolled 600 Black men. 399 of these were cases, meaning positive for syphilis, and 201 were controls, so had no positive test. Participants that tested positive were not informed that they were positive for syphilis. The purpose of the study was not to benefit them or to develop treatment. It was just to observe the progression of disease over time. The participants were also not informed that this was the goal. Penicillin was established as an effective treatment for syphilis 11 years into this study, but the Tuskegee subjects who were positive were not offered this treatment option. The document here to the right is from the Surgeon General in Alabama, early on in the study in the 30s, actually commending the researchers for the amount of treatment that did happen, which was not very much, as being more than they had to do given the purpose of the study, and commending their research and results. The Tuskegee experiment became the basis for the 1979 Belmont Report and was a huge piece in determining the need for higher ethical standards in medicine and medical research, including the introduction of IVR for human studies. As of the 1990s, syphilis was considered largely controlled, mostly because since the discovery of penicillin, it was very, very easily treatable. This treatment was established in the 1940s, and from the 40s up to the 90s, the rates of syphilis globally declined on a relatively rapid scale. There's been a shift in that trend in the last 10 years, however, and the WHO now designates syphilis a re-emerging infection. The graph here to the right shows global syphilis incidence rates from 2015 to 2025, and as you can see, they are quite rapidly increasing. The WHO has made controlling and eliminating congenital syphilis a high priority, due to the fact that as of now, congenital syphilis is one of the leading causes of stillbirth in the world. This is due to global availability of STI screenings not being substantial enough and limited access in many regions to the necessary prenatal care and to penicillin, which can still be used to treat it very, very effectively. Causes of this change in trend and the reemergence of the infection on pretty much every continent is inadequate STI surveillance and inadequate sexual health education, often due to the stigma behind sexual health and the stigma behind educating people about sexual health and funding sexual health. These things in many places have become politicized, and the effect is that they're often inadequate, even in places that could financially provide them. Increased globalization has also caused a reemergence, as have disruptions in healthcare access worldwide, especially post-COVID-19. STI screening rates all over the world declined post-COVID and during the pandemic. This trend is true not only worldwide and not only in developing nations, but in developed ones as well, including in the United States. So specifically United States, resurgence of syphilis and reemergence of syphilis is actually quite dramatic. So since 2000, syphilis rates in the US have increased about 5-fold, and the current rates as of today are the highest documented since the 50s, when treatment by penicillin was just becoming widely used. Congenital syphilis is particularly resurgent, with an increase of 700% in this time period. Reasons for that include mostly structural inequities and just healthcare access gaps. So insurance gaps, barriers to geographic access to care, ability to get care, and particularly for prenatal care for pregnant people. There's also a lot more untreated maternal infection than there used to be. The graph you can see to the right here shows maternal syphilis rates in the United States from 2016 to 2022. This is from the CDC, and these are per 100,000 births. So you can see from 2016 to 2022 the increase in how many pregnant people were positive for syphilis and untreated while pregnant is pretty dramatic. Other things that have factored into the rise in congenital syphilis include housing instability. Rates of syphilis are much higher among unhoused people. And also the stigma associated with it, which affects potentially pregnant people even more. Finally, closing or defunding of STI clinics and STI-related programs has a substantial contribution to this trend too. So even though T. pallidum has no signs of developing resistance to penicillin, and penicillin is still highly effective as treatment and can fully cure the disease, there's widespread resistance among T. pallidum to the antibiotic azithromycin. How this occurred: so azithromycin is orally administered, and it also, in a lot of situations, is an easier alternative treatment to not only syphilis, but a lot of other STIs. So gonorrhea, chlamydia, STIs that maybe the clinician doesn't know what the actual cause is, but they know it's something that could probably be treated by antibiotics, and also preventative treatment, or sort of just in case something is going on and a doctor prescribes it. Azithromycin doesn't need to be refrigerated and can also be administered without any kind of trained clinician because it is not a shot. Penicillin is also a common allergy in terms of antibiotic allergies. So if somebody is allergic to penicillin, azithromycin used to be administered instead, or as sort of a safer option if somebody had never had penicillin and didn't know if they were allergic, but maybe had a genetic tendency towards it. This means that azithromycin was, for a long time, overused and sometimes overprescribed. In a lot of cases, prescription for azithromycin was not given actually for syphilis, but the syphilis bacteria, the spirochetes, were exposed to it in somebody's system when they were being treated for a different STI or for a different reason. Mutations that carried resistance to the antibiotic within the parasite were therefore selected for and favored. And these mutations specifically occurred on genes that controlled binding between azithromycin and the ribosome of the spirochete, so that the drug couldn't block protein synthesis effectively and stop the spirochete from reproducing. When those strains with the mutations for resistance were able to access or enter tight-knit sexual networks, like, for example, city neighborhoods or specific sexual communities, the resistant strains were able to spread very quickly because those networks were so tight-knit. Even though we currently have an effective treatment in penicillin, it is important to take into account this resistance. It does have an effect because it effectively means that there is no alternative to penicillin. So even though penicillin works well, there are cases and situations and places in which access to penicillin or administering penicillin is difficult, if not impossible. Some examples of that would be somebody with a severe allergy would have no alternative if they contracted syphilis to penicillin treatment. Also, areas of the world where access to refrigeration is difficult often don't have easy access to penicillin because it does need to be stored at a low temperature to remain viable and active. Limitations on the ability to treat these cases, even if it's not most people, mean there's higher likelihood for there to be persistent cases of syphilis around in a community, even if it's just a few who are not able to access it. Any more likelihood of persistent cases also means higher likelihood of transmission from those people and spread. So even though T. pallidum